So welcome back friends. So we'll begin with the 25 MCQs. So the first MCQ is, which of the following is not used in the treatment of vestibular schwannomas? The options are X knife, gamma knife, cold knife and cyber knife. I will repeat the question again. Which of the following is not used in the treatment of vestibular schwannomas? And the options are X knife, gamma knife, cold knife and cyber knife. So basically, what is vestibular schwannomas? If anyone can tell. Vestibular schwannomas, if anyone knows, it's a ENT question here. Okay, I will repeat the question. Which of the following is not used in the treatment of vestibular schwannomas? And the options are X knife, gamma knife, cold knife and cyber knife. So basically, vestibular schwannomas are the benign tumor of anyone. Okay, that's a benign tumor of cranial nerve, right? That is the vestibular cochlear nerve. So the options again I will repeat. It's X knife, gamma knife, cold knife and cyber knife. And if no one wants to answer, the answer here is cold knife. Because see, X knife, gamma knife and cyber knife is used, basically it is used in vestibular schwannomas. But the cold knife which I am telling, it is used in, basically it says cervical carcinoma, that is the conization of cervix in cervical carcinoma. So the answer here is cold knife is not used in the treatment of vestibular schwannomas. Okay, next question we have. In the costal roof of which of the following ribs is the classic arrangement of vein, artery and nerve is not seen? Options are 1, 2, 11 and 12. So you might be knowing, normally in the ribs we have like it is vein, artery and nerve. It is like that. So in which of the following ribs it is not seen? 1, 2, 11 and 12. So you have to remember this, basically. You have no option. So the answer here is, anyone? Okay, the answer here is first. Because in first rib you don't see this pattern, that is the vein, artery, nerve. Beside that you see a sympathetic trunk. It is sympathetic trunk, then vein, artery and nerve. That's why the answer here will be second one, or the first one, that is the first rib. First rib. Next question we have, a person is caught in an airport for a case of smuggling of cocaine. Suspecting he has swallowed packets of cocaine, which of the following is the best modality to identify them? And the options are endoscopy, X-ray, MRI, CT scan. So I will repeat, it's a person was caught in an airport in a case of smuggling, that too of cocaine, and they suspecting that he has swallowed packets of cocaine. Which of the following is the best modality to identify? Endoscopy, X-ray, MRI or CT? Anyone wants to answer this? I know mostly you will be telling endoscopy only, but it's not the answer. I'll repeat the options. It is endoscopy, X-ray, MRI and CT. X-ray, no. X-ray not the answer. The answer here it is CT. CT scan is the best modality to identify cocaine packets in the body packer. And what they have given here is, no, it's not that. Patients who swallow cocaine following police pursuit of concealed evidence as termed as body stuffers, and the swallowed packets are oftenly poorly wrapped and can lead to perforate. So it's not there like that. It is only, you have to remember, it is CT. CT scan only is the best modality to identify. Next question we have, what is the treatment of choice for after cataract? And the options are ICC, that is the intercapsular cataract extraction, ECC with PCIOL implantation, and SICS, and last one is ND-YAG laser posterior capsulotomy. So it's a third question. I will repeat the question again. Which is the treatment of choice for after cataract? No cataract. Okay, it's ICC, ECC, SICS or ND-YAG laser therapy, that is posterior capsulotomy. If anyone wants to answer this. ND-YAG is the treatment of choice for this after cataract, that is the secondary cataract you can tell, or it is a posterior capsular opacification. Okay, next question we have. See, a 32-year-old woman presents to you with the complaints of vaginal discharge and itching. On examination, you note a curdy white discharge and an inflamed vagina. What is the best treatment for her? So the options are metronidazole, fluconazole, doxycycline and clindamycin. So curdy white discharge only you can identify metronidazole, fluconazole, doxycycline or clindamycin. Yeah, the answer is fluconazole because you all know it is the candidiasis, candidal vaginitis. So what we give it is we give a single dose of metrozole we don't give. See, we give a single dose of fluconazole, that to 150 mg, which is the best treatment. Yeah. See, intravaginal antifungal, that is imidazole, miconazole, clotrimazole, vaginal pessary or creams can also be given for 3 to 6 days. So yeah, but we give normally we give a single dose of fluconazole 150 mg. Next we have the biopsy of a polyp, reported dysplasia up to the colonic submucosa. Classify this lesion using Haggett's classification. That is the options are level 1, 2, 3 and 4. Basically you have to know what is Haggett's classification, all that otherwise you won't answer. Again I will repeat: the biopsy of a polyp reported dysplasia up to the colonic submucosa. Classify the lesion using the Haggett's classification. Options are 1, 2, 3 and 4. So basically the classification is from 0 to 4. If anyone, okay, I will tell the classification only, then if you want to answer, you can answer. Second, no, it's a level 4, it's not a level 2. See, okay, first classification it is see 0. 0 is carcinoma does not invade the muscularis mucosa. No, it is 4th, yeah. And then level 1 is carcinoma invades through the muscularis mucosa into the submucosa, but is limited to the head of the polyp. So basically 0 is does not invades, second is up to the head of the polyp, and second is up to the neck of the polyp, and third is any part of the stalk, and fourth is it invades the submucosa of the wall below the stalk of the polyp but above the muscularis propria. So I think you understood it is 0 is does not, 1 is head, second is neck of the polyp, third is any part of the stalk, fourth is submucosa of the bowel. Yeah. Next question we have: surfactant appears in the amniotic fluid at, and the options are 28 weeks, 34 weeks, 35 weeks and 36 weeks. Apetone injection for what? Okay. We'll repeat this question. The surfactant appears in the amniotic fluid at 28 weeks, 34 weeks, 35 weeks or 36 weeks. It will be in the amniotic fluid. Anyone? Okay, I'll answer this question. See, you have to remember this. Surfactant appears in the amniotic fluid at 28 weeks. That is 28 to 32 weeks. No, not 34 is not the answer. It is 28 to 32 weeks. That is the range of at which surfactant appears. By week 20 to 24, a primitive alveoli forms and surfactant production begins, but it does not reach the surface of the lungs until later. That is 20 to 32 weeks it goes. And mature levels are present usually after 35 weeks of gestation. And you all know that highly membrane Ds and all that is because of surfactant deficiency. The next question we have: what is the intensity of sound produced during whispering? 10 to 20 decibel, 30 to 40 decibel, 20 to 30 decibel or 0 to 10 decibel. So what is the intensity of sound during whispering? 10 to 20, 30 to 40, 20 to 30 or 0 to 10? Anyone likes to guess at least? Because these are all factual questions, you cannot have to remember. Okay, I will tell you when you normally conversation you do, that is 60 to 65 decibel. And whispering here, the answer is C, that is 0 to 10. But 0 to 10 is not there. 0 to 10 you won't be able to hear only. Best investigation choice is low breathing rate investigation of choice. Yeah, they are right. So 10 to 20, no, it is 20 to 30 decibel is the right answer, because below that you won't be able to hear. See, whispering is 20 to 30. Normally what you talk, it will be 60 to 65, and in heavy traffic it will be 60 to 80, and in factories you will be having 120 decibel. And that see, first I want to tell that normally our ear also listens from 20 to 20,000 hertz. So below 20 you won't be able to listen only. So next question we have: impartition of area of distribution of which of the following arteries is most likely to be seen in patients with hemiplegia? And the options are vertebral artery, middle cerebral artery, anterior spinal artery and posterior cerebral artery. So it is impartition of area of distribution of which of the following arteries is most likely to be seen in patients with hemiplegia: vertebral, middle cerebral, anterior spinal, or posterior cerebral artery. Usually hemiplegia is most common in which artery you have to see, that only, in which artery in person. Which anyone likes to answer? Okay. Okay, the answer here is second, that is the middle cerebral artery. So hemiplegia is most commonly associated with infarction of middle cerebral artery. It supplies the motor cortex responsible for sending the output to the motor neurons. Infarction in the straight eye leads to hemiplegia. Next we have which of the following must be avoided by a patient with tubal pregnancy on methotrexate: sunlight exposure, sexual intercourse, dairy products, NSAIDs, and azithromycin. It's a multiple choice question, so the options are like 1, 3, 5, 1, 4, 5, 2, 3, 5, and 1, 2, 4. So you have to tell, basically it's a multiple choice. Which of the following must be avoided in a patient with tubal pregnancy on methotrexate: the sunlight exposure, sexual intercourse, dairy products, NSAIDs, or azithromycin. Anyone? And why? If you know the answer, you can tell why also, why it is avoided with tubal pregnancy. Okay, the answer here is, see, 1, 2, and 4, that is sunlight exposure, sexual intercourse, and fourth is NSAIDs. They must be avoided in a patient with tubal pregnancy on methotrexate. Now see why. See, first is sunlight. Because sunlight may provoke methotrexate related dermatitis. So dermatitis is associated with sunlight exposure. Second is sexual intercourse. In sexual intercourse, it can rupture the ectopic pregnancy. Yeah. And fourth was NSAIDs. NSAIDs can reduce renal blood flow and delay drug excretion. So you cannot have sunlight exposure, sexual intercourse, and NSAIDs. You also cannot have alcohol because it can predispose to hepatic enzyme elevation and other also. Yeah. Next question. What is the gold standard for diagnosis of Peroxisomal nocturnal hemoglobinuria? Ham's test, bone marrow biopsy, Hplc, Fluorocytoma. This you can answer. What is the gold standard for diagnosis of Peroxisomal nocturnal hemoglobinuria? Ham test, bone marrow biopsy, Hplc, or flow cytometry. Anyone gold standard? Yeah. Okay, yeah. So the answer here is, if no one wants, okay, the answer is D, right? In the flow cytometry. Yeah, D is the right answer. Flow cytometry is the gold standard for PNS, that is Peroxisomal nocturnal hemoglobinuria. It provides a sensitive means for detecting red cells and other deficiencies in GPI-linked proteins such as CD59. See, Ham test, bone marrow biopsy, and all other. Bone marrow is not one, is there, but you cannot say it is gold standard. See, bone marrow, yeah, it will be hypercellularity with erythroid hyperplasia will be seen in classical presentations, and patients who develop pancytopenia will have hypocellular bone marrow. It can be there. Ham test also is there, but gold standard is flow cytometry. It's a sensitive. Next question we have, see, a 29-year-old prima gravida at 4 months of period of gestation and a history of juvenile myoclonic epilepsy visits your clinic. She has been regularly taking sodium valproate and is now concerned about the medication possibly affecting her child. So what would you suggest to this patient? Options are: immediately taper valproate and start lamotrigine. Second is continue valproate with serial drug monitoring. Third is switch to carbamazepine, and fourth is add lamotrigine to valproate. So it's a 29-year-old prima gravida, fourth week of period of gestation, history of juvenile myoclonic epilepsy, and regularly taking sodium valproate. Now concerned about her medication because it's affecting her child. So what would you suggest to the patient? Immediately taper and start lamotrigine, continue valproate with serial monitoring, switch to carbamazepine, and add lamotrigine to valproate. At least try this one if you don't know the answer also. Who wants to answer this? Second is the right answer. See, continue valproate with serial drug monitoring. See, it should be D. D is not the right. See, because D adding additional just to stabilize doses may increase teratogenicity. Because sodium valproate already teratogenic drug it is. So adding lamotrigine to valproate is also not a viable option here. Continue. Yeah, that's the right answer. See, valproate has a high teratogenic potential, what I said, and it is usually avoided before conception if other anti-epileptic with less teratogenicity can be used. But for a woman who is pregnant and already taken valproate, changing the drug is not recommended. So you just decrease the serial monitoring you will do. Next we have in a patient with sleep apnea, what should be the minimum duration of cessation of breathing of each episode? 10 seconds, 20, 30 and 40. So patients with sleep apnea, what is the minimum duration of cessation of breathing of each episode? 10, 20, 30 or 40? Yeah, anyone? Okay, the answer here is A, that is 10 seconds. In this we have to, it's a factual question. An episode of sleep apnea is defined as 20 not there. It's an episode of sleep apnea is defined as a cessation of breathing for 10 seconds or more during sleep. What is 5? So during an obstructive sleep apnea, the respiratory efforts continues, but airflow ceases due to loss of airway patency. And a reduction of airflow by at least 30% for 10 seconds or more is termed hypopnea. Yeah, the answer is 10 seconds. See, there is a loss of airway patency because it can be because of tongue also, it can go back. So yeah, the answer is 10 seconds. And reduction of airflow by at least 30% for 10 seconds is termed as hypopnea. Next question we have, it's a big question. Okay, a 3-year-old African child is brought to India seeking affordable healthcare for his rare hemolytic disease. He has an undiagnosed hemolytic disease since infancy and has now developed cholelithiasis. MCV is extremely low, 30 to 50 femtoliter. MCHC is normal and osmotic fragility is increased. Now you do a peripheral smear. A peripheral smear shows changes in red cell morphology, which include extreme poikilocytosis, microspherocytosis, microepilepticocytosis, membrane budding and cell fragments. Genetic studies reveal a mutated spectrin gene. What is the most likely diagnosis? So it's a very big question. Okay, the options are hereditary spherocytosis, hereditary epilepticocytosis, hereditary pyropoikilocytosis and hereditary stomatocytosis. 30 desaturation, yeah, that's right. So now this question, I think it's a big question again. See, a 3-year-old African it's a rare hemolytic disease. He was undiagnosed hemolytic disease since infancy, now developed cholelithiasis. MCV is low, MCHC is normal, osmotic fragility is increased. Peripheral smear shows change in red cell morphology, which includes extreme poikilocytosis, microspherocytosis, microepilepticocytosis, membrane budding and cell fragments. Genetic studies reveal a mutated spectrin gene, which is the most likely. Just tell me, genetic studies reveal some mutated spectrin gene in which condition? All that is nonsense. Hereditary spherocytosis, hereditary epilepticocytosis, hereditary pyropoikilocytosis and hereditary stomatocytosis. Hereditary spherocytosis. I also thought that, but it's not the answer. Okay. The answer here is hereditary pyropoikilocytosis. It's a type of hemolytic anemia that is associated with cytoskeletal protein defect causing extreme variation in RBC size and shape. So yeah, it's a hereditary pyropoikilocytosis associated with alpha spectrin defects, thermal sensitivity, that is fragmentation at 44 degrees Celsius, extreme variation in RBC. So basically it's you have to remember this. Hereditary epileptocytosis is more accurate. See, but in pathology is in hereditary epilepticocytosis, the pathology is different as told in the question, because in that it is oval, elongated, thin dot or cigar-shaped RBCs associated with spectrin gene mutations. Pathology changes. Basically, you have to read the question twice, then only you will understand. I also read twice, but okay. Next question, let's be a shorter question now. Next, we have a 200 mg of drug is administered to a patient, of which 20 mg is extracted in 90 minutes. How much of the drug will remain after 3 years if it follows first order kinetics? Options are 162 mg, 145.8 mg, 50 mg and 40 mg. You have to calculate light half-life and all that. Again, I will repeat, it's a 200 mg of drug is administered to a patient, of which 20 mg is extracted in 90 minutes. So how much of the drug will remain after 3 hours if it follows first order kinetics? So first order kinetics, you have a formula, I think you know. If anyone wants to try. I have to calculate basically in this. Okay, calculate. Okay, I'll tell this if you don't want to calculate. The answer here is 162 mg. At what you have told, which will remain after 3 years. 3 years is 162 mg will be remain. How? Because you know in first order kinetics, what you know, the constant fraction of drug is extracted every time. It is a constant, not like other kinetics. So you have to tell like say 20 mg after 200 mg is extracted in 90 minutes. Then 20 by 200 equal to 0.1 fraction is eliminated every 90 minutes after 90 minutes. You have to calculate for every fraction, that is after 90 minutes it is 200 minus 20 mg, that is 180 remains, and after again 3 hours equal to it is 180 minus 18, that is 162 mg remains. So yeah, basically you have to after every hour you have to calculate and then have to tell how much it remains. So the answer is 162 mg it remains. Next we have multiple inmates at a person at a prison are suspected to have epidemic typhus following an arthropod infestation. Which of the following vectors is implicated in the spread of the disease? I don't know this question. I will come. They have given the pictures of the arthropods. How will I show you that? Okay, just tell me. You can just tell me which is the arthropod causing this epidemic typhus, and that at least you can tell. Which arthropod will cause epidemic typhus? The monoquality agent you can tell. Which it is a vector? Anyone? Okay, the answer here is louse. Louse, that is, you can name is Pediculus humans corporis. It transmits epidemic typhus. So you have to remember this name, louse. That is the Pediculus humanus corporis. Next we have AIMS 65 score is used to predict mortality rate in patients with which of the following? And the options are upper GI bleed, lower GI bleed, carcinoma esophagus or carcinoma rectum. So AIMS 65 score is used to predict which mortality rate in patients of which of the following? Upper GI, lower GI, carcinoma esophagus or carcinoma rectum. It's a classification basically. If you have read GIT, then only you can answer this. Yeah, louse was the answer. For this you can answer AIMS 65, AIMS 65, it is used for predicting the mortality rate in patients of which of the following? Upper GI, lower GI, carcinoma esophagus or carcinoma rectum. Okay, the answer here is upper GI. That is the upper GI bleed, because AIMS 65 is a simple risk score that predicts the mortality rate in patients with upper GI, and it is a scoring system basically for upper GI. It is a scoring system like albumin less than 3 gram per deciliter score 1, INR. You just remember what are the variables used in this scoring system. That is albumin, INR, altered mental status, systolic BP less than 90, A greater than 65, and overall if you have a score greater than 2, that is high risk. Next we have, it's a pathology question. A 60-year-old male presents with you with history of intractable diarrhea. Based on the histological image shown below, which of the following is the most appropriate diagnosis? So they have given a histological picture and history is intractable diarrhea only. Okay, the pathological features. Okay, yeah, you can just tell like this. Russell bodies are there, so you can just tell Russell bodies are seen in which conditions. Russell bodies, and there is a history of intractable diarrhea. So the options are lymphoma, leishmaniasis, ureate nephropathy, and multiple myeloma. Russell bodies are seen in which conditions? And what are Russell bodies? Till then I will tell. You just think and tell the answer. Russell bodies are eosinophilic, large, homogeneous immunoglobulin containing inclusion usually found in a plasma cell undergoing excessive synthesis of immunoglobulins. Usually from this only you can tell it is a immunoglobulins is seen in which condition? Lymphoma, leishmaniasis, ureate nephropathy, or multiple myeloma. Anyone? Okay, the answer there is multiple myeloma. Because in multiple myeloma only you will see immunoglobulins in the plasma cells. We are asked called Russell bodies, which is seen in the pathological image. Yeah, multiple myeloma is the right answer. Next question we have, a 35-year-old male with chronic bacterial prostatitis was treated with cortimosozole. He develops malaise, jaundice, abdominal pain, and dark urine. So the blood picture they have given below, the most likely diagnosis is. Okay, I will repeat the question. It's 35-year-old chronic bacterial prostatitis, and he was treated with cortimosozole, and it develops malaise, jaundice, abdominal pain, and dark urine. And they have given the blood picture, that is the peripheral smear they have given here, and it shows bite cells. So remember, bite cells in which condition? Bite cells or degmacytes or blister cells, you can whatever you can tell. But yeah, bite cells is which condition? The options are hemolytic uremic syndrome, autoimmune hemolytic anemia, Peroxisomal nocturnal hemoglobinuria, or GC period deficiency. So bite cells is seen in which condition? Anyone? So basically what happened here is, if you give a drug that is cortimosozole, there is some reaction with the drug only. It's an acute hemolytic reaction following the administration of cortimosozole. Now you can tell. Okay, the person here is having Hplc. The answer is right, because hemolysis is there. Yeah. So the person here is having Hplc deficiency, and what they have given is cortimosozole contains sulfamethoxazole, which triggers a hemolytic reaction in a person with Hplc deficiency. So here the answer is Hplc deficiency because of the drug itself. Next we have, it's a PSM question. A village has a total population of 1 lakh, okay, with an under 16 population at 3%. The prevalence of goiter in an under 16 population is 0.3 by 100. What is the total number of under 16 population affected by goiter? I'll repeat. Village has a total population of 10 lakh it is. Village has total population of 10 lakh with an under 16 population at 3%. Prevalence is 0.3 by 100. What is total number of under 16 population affected by goiter? Options are 90, 9, 10 and 100. Anyone who likes PSM can answer this. Okay, the formula they are given, it is, number of total under 16 population is 3%. See, because it is given 0.3 by 100. So that is 3%, and that too they have given it is 10 lakh. 3% of 10 lakh will be 3000. Okay, and the total number of goiter patients who are under 16 will be having 3000 by 0.3, that 3000 into 0.3 by 100, that is equal to 9. You have to remember the formula of incidence, that is number of new cases of a disease in a specified period of time by population at risk into 1000. 90, no, it's 9. Some calculation mistake you might be having. Basically they are asking prevalence. Yeah. So the prevalence formula is number of all cases of a specified disease at a given point of time by estimated population at the same time into 100. Okay, next question. Identify the gas cylinder based on the pin and its zone. How will you say that? Okay, I will tell this. It's an anesthesia question. Suppose there is a gas cylinder. Identify a gas cylinder based on the pin index. And the pin, what is the pin they have given? Pin has 2 holes. So you have to remember like this. Which is the in which cylinder you have to 2 holes, because there is 3 holes, 1 hole also, like that you have to, you know, basically in anesthesia like that only we have. So each gas cylinder has 2 holes in its cylinder wall that fits the corresponding pin. So but yeah, there are also 2 holes, if anyone can tell. Okay, the answer is nitrous oxide. Pin index system is a safety measure to prevent incorrect cylinder attachment. Each gas cylinder has 2 holes in the cylinder wall that fits to the corresponding, that all. But for all it is a different image is there. Okay. Next we have a pregnant woman complains of intense nocturnal itching for the past few days. She has the following finding on examination. What is the drug of choice for this case? Drug of choice for this condition. I can tell you the diagnosis because I cannot tell the image here. Again I will repeat. It's a pregnant woman who complains of intense nocturnal itching for the past few days. She has the following finding on examination, and what is the drug of choice for this? Okay. I can tell you the diagnosis here is scabies. Now you can tell. Now anyone can tell. I think what is the drug of choice for scabies? Just tell that. Ivermectin, permethrin, gamma benzene hexachloride, crotameton. This anyone can tell. It's an easy question. Drug of choice for scabies: ivermectin, permethrin, gamma benzene hexachloride, or crotameton. Yeah, anyone? Okay, the answer here is, I think you might be knowing, but yeah, the answer is permethrin. And what you will do here is you will do a single overnight application of 5% permethrin from the neck to toe in adults and from head to toe in children is the drug of choice here. Scabies. For scabies we have 5% permethrin cream we will use. Next we have again an image based question we have given. Okay, the image shows the Stanford type A aortic dissection is. I cannot show the image, sorry for that. Okay, next question. Permethrin, permethrin is the right answer. Next we have a middle-aged man is there who presents to a clinic with a history of progressive wrist pain. Examination reveals stiffness of the wrist joint. A radiograph of the wrist is shown below. What is your provisional diagnosis? Okay, and the options are Sever's disease, Kienbock disease, Kohler's disease, and Osgood skeletal disease. And what is the picture they have given? It's a X-ray which shows increased opacity of the lunate due to interrupted blood supply. Okay, just tell me, there is a progressive wrist pain, stiffness of the wrist joint, and radiograph shows opacity of the lunate. Now what will be the diagnosis? Sever's disease, Kienbock disease, Kohler's disease, or Osgood skeletal disease? I think you have heard or not, I don't know all these names also. It's an increased opacity of the lunate will only give you a diagnosis. Okay, the answer here is that is the B, that is the Kienbock's disease. And what is the Kienbock disease? Kienbock is basically refers to the avascular necrosis of the lunate, and it's called progressive wrist pain will be there, and presents with tenderness over the lunate and stiffness of the wrist joint. And others also I will tell. See, the first option was Sever's disease. So it was also inflammation of the calcaneus. So if it is a calcaneus, then Sever's. If it is a lunate necrosis, it is a Kienbock disease. And if it is a navicular we have, if it is a avascular necrosis of navicular bone, it is Kohler's disease. And if it is an inflammation of the patellar ligament and the tibial, they are all new. Yeah, for me also it is new. And for inflammation of the patellar ligament and the tibial tuberosity, it's Osgood skeletal disease. So I think now we are very clear. If it is a lunate, Kienbock disease. If it is a calcaneum, it is Sever's. If it is a navicular, it is Kohler's. And if it's a patellar ligament at the tibial tuberosity, it's Osgood skeletal disease. Next question we have, last question for today. It's a 60-year-old male patient presents with you with 2 weeks of productive cough, fever, and shortness of breath. A chest radiogram was done as shown below. Okay, which of the following is the most appropriate therapy for him? So okay, I will just tell what it is showing. See, the chest radiogram. Okay, the chest radiogram, lung abscess is there. I'll repeat, it's a 60-year-old, 2 weeks of productive cough, fever, shortness of breath, and the chest radiogram shows lung abscess is there. Which of the following is the most appropriate therapy for him? Cephalexin, ciprofloxacin, clindamycin, and vancomycin. So basically, you have to tell what is the drug of choice for lung abscess. Cephalexin, ciprofloxacin, clindamycin, and vancomycin. Yeah, this is the last question. Anyone can at least try. Cephalexin, ciprofloxacin, clindamycin, or vancomycin. Okay, I will tell the answer. Yeah, the answer is clindamycin. So clindamycin is a drug of choice for lung abscess. And if it is a contraindicated, cephalexin, no, it's clindamycin. And suppose clindamycin is contraindicated, then we use a combination of penicillin and metronidazole, which is likely to be effective as clindamycin. No, it's C is the answer here. Clindamycin is the answer. And anaerobes of the oral origin are most common causative organism and all that. Okay, that's okay. Yeah, the answer for lung abscess is clindamycin is the drug of choice for this. So yeah, we got over by 25 MCQs. So yeah, thank you so much. Yeah, A is not the answer. Clindamycin is the right answer. Yeah, okay. Thank you.